What is brachytherapy? Brachytherapy is radiation therapy that involves the development or placement of radioactive sources, called seeds, in intimate contact with the cancerous tumor or the gland within which the tumor is located. The radioactive sources are small, each about the size of a grain of rice. Their small size permits their insertion into or onto tumors, allowing the radiation stemming from the seeds to interact and kill neighboring tumor cells but causing minimal harm to healthy tissue further away from the tumor. Some radioactive sources used for brachytherapy are iridium-192, half-life is 74.17 days, iodine-125, half-life is 60.25 days, and palladium-103, half-life is 16.96 days. These radionuclides have relatively short half-lives, permitting brachytherapy seeds to be inserted into a cancerous tumor and never removed. The radioactivity in the seed decays, emitting lethal radiation to cancer cells until no detectable radiation remains in the seeds. This is often the practice with the treatment of prostate cancer. The seeds are never removed but remain harmlessly in the prostate for the rest of the patient's life. Let's discuss a brief history of brachytherapy. The word brachy is derived from Greek brachus, meaning short. Brachytherapy dates back to 1901, shortly after the discovery of radioactivity by Henry Becquerel in 1896. When Pierre Curie suggested to Henry Alexander Dunlos that a radioactive source could be inserted into a tumor. The first successful radium brachytherapy was the skin irradiation of two patients with basal cell carcinoma in St. Petersburg in 1903.
What is brachytherapy and how is it used? Brachytherapy, also called internal radiation therapy, places radioactive material directly inside or next to the tumor. It uses a higher total dose of radiation to treat a smaller area than external beam radiation therapy or EBRT, which directs high energy X-ray beams at a tumor from outside the body. Brachytherapy treats cancers throughout the body including the prostate, cervix, head and neck, skin, breast, gallbladder, uterus, vagina, lung, rectum, and the eye. There are two types of brachytherapy implantation: temporary and permanent brachytherapy. Temporary brachytherapy places radioactive material inside a catheter for a specific amount of time and then removes it. It is given at a low dose rate or high dose rate. Temporary implants use needles, catheters, or special applicators. After the device's accurate position is confirmed, the radiation sources are inserted. This is called afterloading. The oncologist may use a computer-controlled remote afterloading machine to insert the material. Medical imaging helps position the material to treat the tumor in the most effective way. A computer calculates the source position and the amount of time needed to deliver the desired radiation dose. Permanent brachytherapy is also called seed implantation. It puts radioactive seeds about the size of a grain of rice in or near the tumor permanently. After several months, the seeds lose the radioactivity. Inactive seeds are harmless and rarely trigger metal detectors. Permanent implants put radioactive seeds directly in the tumor using a special delivery device. This is usually done in ultrasound and or X-ray imaging to ensure accurate placement. Note that the medical physicist, licensed dosimetrist, or radiation oncologist operates the equipment. The oncologist creates the overall treatment plan.
Radiation protection in brachytherapy. Most radioactive sources used for brachytherapy either incorporate a metallic shield within the applicator or use an isotope that emits low energy photons that are shielded by the patient. Radiation dose does not travel far outside the treatment area, which means the chance of exposure to others is low. However, there are recommended radiation safety precautions for both patients and medical professionals during a brachytherapy treatment. This may vary depending on the sources and activity used for an individual implant. First, HDR brachytherapy treatments are performed in a radiation therapy vault. The patient remains in the treatment room alone while the source is outside of its shielded housing to limit exposure to staff and members of the public. Second, if visitors are allowed during the course of a temporary LDR treatment, they should spend no more than 30 minutes with the patient. Lastly, all implants are tested and sealed before they are implanted to ensure that the radioactive material inside of them does not leak. Their placement inside the body is also unlikely to change or move. Dosing. The dosing used in brachytherapy varies based on the type of tumor being treated, radioisotope, dose rate, the LDR or the HDR, number of treatments planned if using HDR, and timing, adjuvant or definitive. Dose rate. Brachytherapy is typically described by the rate at which the dose is delivered. Three categories have been established to categorize brachytherapy. These include high dose rate or the HDR brachytherapy delivered at more than 12 ray per hour, pulse dose rate or the PDR delivered at 10 to 30 minute intervals at a rate of zero point 0.5 to 1.0 gray per hour. Medium dose rate or the MDR offered at 2 to 12 gray per hour, and low dose rate or the LDR brachytherapy delivered at zero point 0.4 to 2.0 gray per hour. Isotopes. Several radioactive isotopes may be used for brachytherapy. These isotopes are artificially manufactured using a nuclear reactor. Iridium-192 is the most commonly utilized radioactive isotopes for HDR brachytherapy or the high-dose rate brachytherapy treatment. The LDR isotopes or the low-dose rate isotopes tend to have lower energy because of the decay by the electron capture and have far lower dose rates. Equipment used in brachytherapy, applicators, and the remote after loading. Applicators, this is designed to house the radioactive isotopes during treatment. Examples of applicators that may be utilized. MIC applicator, most well known and used for interstitial permanent seed implantation for prostate brachytherapy. It allows for the precise placement of loose seeds into the prostate. Vaginal cylinder, used for uterine cancer or post-operative patients with cervical cancer. It uses high-dose radiation after loader. Tandem and ring or avoid. Used in intact cervical cancer cases, radiation can be delivered using high or low dose rate. Breast brachytherapy applicator. Most widely used breast therapy applicator. This allows for accelerated partial breast irradiation or the APBI in select patients with early stage of breast cancer. It utilizes high dose distribution around the surgical cavity.
Remote afterloading. Commonly used for high-dose rate brachytherapy with high-energy radioisotopes. A remote afterloader consists of a shielded safe where the high-activity radioactive source resides. They require dedicated shielding room with an audio or visual surveillance. The source is connected to a super elastic nickel titanium wire, and the wire is attached to a stepper motor which allow the source to be advanced by a fixed distance and predefined dwell times with an accuracy of 1 millimeter. The source can travel at a maximum speed of 50 cm or second and dwell for as little as 0.1 seconds. Remote afterloading has resulted in a substantial reduction of staff radiation exposure. The difference between low-dose rate brachytherapy and high-dose rate brachytherapy. With low-dose rate brachytherapy, doctors insert tiny seeds containing radiation in or near the tumor while the patient is under anesthesia. LDR brachytherapy typically takes a little over an hour and does not require an overnight stay in the hospital. Usually, the seeds are permanent, but they cause little or no discomfort, and the radiation activity lessens after several weeks or a few months. In some cases, such as the treatment of eye tumors, the implants are removed after several days. In high dose rate or HDR brachytherapy, doctors typically give concentrated bursts of radiation in a short amount of time, with the patient under anesthesia. A number of plastic catheters or tubes are inserted into or near the tumor. The catheter are attached to a machine that contains precise doses of radiation in the form of radioactive pellets. For skin cancer, HDR brachytherapy uses electronically produced radiation that is given off the skin surface without need for catheters. Image-guided brachytherapy and treatment planning system. Advanced computing technology has revolutionized brachytherapy planning, particularly in treating breast, cervical, and prostate cancer. CT, MRI, and ultrasound-based planning have significantly changed the process, allowing for three-dimensional target definition, dwell weight optimization, and the generation of isodose calculations. CT-based planning allows for real-time evaluation of dose distribution using actual implant geometry, while MRI-guided brachytherapy has gained popularity in cervical cancer treatment due to improved target accuracy and reduced dose to normal structures. However, it has limitations such as added cost, operative time, and additional personnel required. Ultrasound is widely used in brachytherapy planning and directing needle placement, being more cost-effective and less time-consuming than CT. Transrectal ultrasound-guided prostate brachytherapy is considered the standard imaging modality and essential for replanning. Intraoperative planning, implementation of interstitial needles, and the seed disposition. Modern treatment planning systems allow inverse planning to determine the optimal number and position of each seed within the prostate given a set of those constraints. Before computerized brachytherapy planning and remote afterloading, the planning process relied on several empirical systems, such as the Manchester system, Quimby system, and the Paris system. The Manchester system was devised in the 1930s by Herbert Parker and Ralston Patterson, focusing on dose homogeneity within the target by concentrating radioactivity in the periphery of the implant. The Quimby system uses equal intensity implants distributed uniformly throughout the implant, with central doses 25 to 30% hotter than the prescription dose of 1000 centigrade. The Paris system was devised by introducing new iridium-192 base afterloading techniques and pacing out radium implants. Developed in the 1960s, requires the target's thickness, length, and width, spacing dictated by the implant's thickness, and the number of sources by the cross-sectional area. The prescription dose is 85% of the basal dose, calculated by averaging the minimum dose between adjacent equidistant sources in the transverse plane. Originally designed for single and double plane implants, the maximum thickness can be treated with this system is 2.5 cm.